Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 7. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. While it seems tempting to skip ahead to discover the treatment that I recommend, you will miss the value of this clinical journey that I am sharing with you. Article number 7. Pain is not the only problem. Mental and behavior contributors. These articles intend to 1. Reevaluate the prevailing clinical practices thought to manage low back pain. 2. Submit and debate novel low back pain contributors and mechanisms. 3. Meet patient expectations and satisfaction in clinically meaningful results. 4. Recommend a conservative, non-surgical course of care to override pain instantly. And 5. Restore ADLs and patient confidence on the first visit at low cost. Traumatic low back pain aside, there are 6 possible categories to organize low back pain. Classical orthopedic exams would likely not rule out these. Number 5, mental, and number 6, behavior contributors. It hurts when I think about it, says the patient. Low back pain does not exist in isolation. When we look for low back pain contributors, we should be careful not to neglect the entire person that is having the experience of symptoms and interruptions to enjoying their usual lifestyle. Mental contributions might be overlooked for a variety of reasons in the clinician's office, possibly office scheduling issues, scope of practice issues, clinician experience issues, and course of care issues. Regardless of the reasoning for the issues, the clinician should provide an unhurried overview of the patient's mental and behavior presentation of habits, values, expectations, and biases. Non-physical contributions can make low back pain worse. Expectation modulation describes a fearful patient. A patient may present with guarding, antalgia, fearing certain motions or body positions. These actions should not be casually oversighted, since these actions and shapes describe an entire person consumed by their pain. The patient may have an emotional history with low back pain, or with any pain possibly related to depression, anxiety, and fear that can exacerbate their low back pain, and that can lead to sympathetic syndrome and amplification. Since emotionality is connected to gut health, the patient may exhibit chronic gut complaints and symptoms, furthering fears about complete and unmitigated pain and illness. Certain patients are prone to back pain ownership. My stupid back pain. My sciatica from 10 years ago, said the patient. The patient may blame their low back pain as if it had attacked them from the outside of their body, an invader, verbalizing it in the third person rather than as a lived experience. The back pain is a literal thing. With time, low back pain fuels patient frustration, and it takes 2 forms. 1, frustration with the pain itself, and 2, frustration with the medical system's inability to help the patient feel and get better. Good and excellent clinicians should have no problem satisfying any low back patient in a few visits, managing 6 to 8 weeks of conservative care that includes primarily patient education and home exercise. Frustration is easy to avoid in the clinician's office if the doctor simply says, I promise you, low back pain is very well understood within the scope of medicine, and I promise you that you will be feeling much better very soon and able to do your usual lifestyle activities with no problem, I promise. I say this to every patient in my office for 4 reasons. 1, it reassures the patient that their symptoms will be under control. 2, it reassures the patient that their complaint is under control because it is not a mysterious, potentially untreatable disease. 3, it puts my personal word on the line to do a good work. And 4, it makes me feel like an amazingly good doctor. Patients fear delay in care and for getting lost in the system. They fear gaps in employment or job loss. They fear for the day that they will have to go back to work with low back pain and push through their low back pain, praying that it will just go away. Behaviors can change when a patient is dealing with long-term unresolved low back pain. They may develop health identity distortion, HID, the idea that someone else is responsible for their health, become a victim, become aggressive with their doctor, and blame others. They may not eat enough food, fearing the ability to afford food to pay medical bills or due to loss of work. They may stop exercising, become less active with their family, miss family time altogether, or fear movement due to expectation of pain. Sports patients may not commit to full training programs or reduce recovery programs. Athletes with low back pain may fear for the inability to compete, fall behind, or be cut from the team, and may train secretly or succumb to the coach's insistence that the athlete continue to train anyway. Physicians can be certain that pain is not the only problem. Patients are less of a biological study and more of an emotional study. Please pay attention to the important mental and behavior contributors to low back pain, and by all means, promise them anything that you think will help them feel and get better. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.